Good morning, ladies and gentlemen. I'm Jordi Marchand. I am a medicine student of the Catholic University of Santiago de Guayaquil. Today I will talk to you about antimicrobial prophylaxis for children with vesicoureteral reflux. Definition: vesicoureteral reflux is present in one-third of children presenting with febrile urinary tract infection and has been associated with a heightened risk of renal scarring. We designed a randomized intervention for children with vesicoureteral reflux review to determine whether long-term antimicrobial prophylaxis is effective in preventing febrile or symptomatic recurrences and the extent to which it contributes to bacterial resistance.
I understand our daughter Elizabeth had a urinary tract infection, and our doctor had treated her with antibiotics. Would you be able to give us information about the reflux that was found on the VCUG?
So normally urine flows from the kidneys down the ureters into the bladder. Vesicoureteral reflux occurs when urine from the bladder flows back into the ureters all the way up into the kidneys. This occurs if the valves at the bladder do not work properly. And about 1/3 of children with urinary tract infections have vesicoureteral reflux, which is graded on a scale from 1 to 5. Urine can back up only a short distance, and that would be a grade 1, or all the way up and dilate the ureters into the kidney, and that would be a grade 5. This allows bacteria from the bladder to get to the kidneys, causing kidney infections with back pain, fever, or chill. Repeated or severe kidney infections may cause scarring and rarely lead to high blood pressure or later in life complications during pregnancy or kidney failure.
Two clinical presentations blur. Prenatal, male plus female. Blur diagnosed prenatally by US. Severe blur common. Significant rate spontaneous resolution, but renal hypoplasia and dysplasia frequent. Increased risk renal failure and hypertension. Postnatal, mostly female. Presents at febrile UT. Spontaneous resolution is a function of age and grade. Pure grading. Grade 1. Reflux only fills the ureter without dilation. Grade 2. Reflux fills the ureter and the collecting system without dilation. Grade 3. Reflux fills and mildly dilates the ureter and the collecting system with mild blunting of the calyces. Grade 4. Reflux fills and grossly dilates the ureter and the collecting system. 1/2 of the calyces are blunted. Grade 5. Massive reflux grossly dilates the collecting system. All the calyces are blunted with a loss of papillary impression, and intrarenal reflux may be present. There is significant ureteral dilation and tortuosity. Signs and symptoms. Vesicoureteral reflux may present before birth as prenatal hydronephrosis, an abnormal widening of the ureter, or with an urinary tract infection or acute pyelonephritis. Newborns may be lethargic with faltering growth, while infants and young children typically present with pyrexia, dysuria, frequent urination, malodorous urine, and git symptoms, but only when urinary tract infection is present as the initial presentation of BUR. Causes: primary BUR, insufficient submucosal length of the ureter relative to its diameter causes inadequacy of the valvular mechanism. This is precipitated by a congenital defect lack of longitudinal muscle of the intravesical ureter, resulting in an uretero-vesicular junction (UV) anomaly. Secondary view. The obstructions may be anatomical or functional. Anatomical: posterior ureteral valves, ureteral or meatal stenosis. Functional: bladder instability, neurogenic bladder and non-neurogenic. Neurogenic bladder urinary tract infections may cause reflux due to the elevated pressure associated with inflammation.
Endoscopic repairs correct VUR by injection of a bulking substance that allows elevation and coaptation of the ureteral orifice and detrusor tunnel. The method currently achieving the highest radiographic success rates is the double hit method, with results approaching that of ureteral reimplantation. This video will focus on the endoscopic correction of VUR using the double hit method. The patient is a 4-year-old girl with recurrent E. coli urinary tract infections who was diagnosed with early filling right grade 3 VUR on voiding cystourethrogram. Hydrodistension is graded according to the distensibility of the ureteral orifice, with a non-hydrodistending ureter graded as an H0 and the most significant degree of hydrodistension graded as an H3 ureter, where the extramural tunnel is evident outside of the bladder. Hydrodistension allows visualization of the intraluminal injection site as well as assessment of injection progress. Ureteral hydrodistension causes the orifice to open before treatment, but following proper implantation, the ureter should remain closed with an H0 grade. Hydrodistension grading correlates with VUR grade, with higher hydrodistension grades requiring more injected volume. Typically, between 1 to 2 cc's are required for H2 to H3 ureters. In this particular case, both ureters hydrodistend to a grade 3. Therefore, both ureters will be treated during the same session. When employing the double hit methodology, the needle is placed into the ureteral orifice and inserted in the mid-ureteral tunnel at the 6 o'clock position during hydrodistension. Once the needle is in place, the scope is placed at the level of the ureteral orifice, allowing for position of the needle to be assessed. The needle is inserted to approximately 1 to 2 millimeters. It is important that the surgeon also be the injector, as subtle tactile feedback may be missed. Injection should proceed slowly. During the injection process, blanching and mounding of the tissue should occur. It is also very important to pull back the cystoscope during the process to get a bird's eye view of the implant to assure proper implant location. Bulking agent is injected until a sufficient bulge is produced, which coapts the detrusor tunnel. An alternative to the straight metal needle is the inject needle. Hydrodistension is not required as a filiform wire is placed within the ureteral orifice. The site and depth of needle insertion is controlled by a retractable needle and a gauge on the needle hub. Once the needle is extended into the tissue, rotation of the needle will also rotate the ureteral orifice, thus confirming proper insertion. The injection then proceeds as described with the conventional metal needle. Following the proximal hit, a second injection at the distal-most aspect of the intraureteral tunnel results in coaptation of the orifice. In this case, an identical procedure was performed on the left ureter due to abnormal ureteral hydrodistension. Hydrodistension with the bladder nearly empty is performed following each injection to monitor progress. Additional injections may be needed to achieve an H0 ureter during hydrodistension. Objective endpoints of injection are the loss of hydrodistension with bladder empty and increased tissue turgor. The needle is used to depress the implant. Poor turgor will result in deformity of the implant, indicating that more volume is needed. In our long-term experience with the double hit method, both radiographic and clinical success at 1-year follow-up was 93%. Importantly, 95% of patients avoided open surgery during a 4-year follow-up.
I'm Peter Feniak. The doctor has told you that your child has been diagnosed with vesicoureteral reflux. As a parent myself, I know you'll have questions, so during this video, I'll explain what vesicoureteral reflux is, why reflux is a problem, and how reflux can be managed. Later on, we'll ask you to fill out a confidential survey indicating which treatment you'd prefer. The urinary tract is made up of 2 kidneys, 2 ureters, the bladder, and the urethra. The kidneys filter the blood to form urine. Urine is then transported by the ureters from the kidneys into the bladder, where it's stored. When it's time to urinate, the bladder empties through the urethra. Normally, there are small flap valves where the ureters meet the bladder. These valves stop urine from flowing backwards from the bladder into the ureters. When these valves are defective, urine backs up from the bladder into one or both of the ureters, a condition known as reflux. Reflux severity is graded on a scale of 1 through 5. 1 is the mildest, while 5 is the most severe. Children with grade 5 reflux may never outgrow the problem, but younger children and those with mild reflux have the best chance of outgrowing it. Children under the age of 1 may outgrow it in just a few years.
Diagnosis: Nuclear cystogram, REC, fluoroscopic voiding cystureterogram, VCUEG, ultrasonic cystography, abdominal ultrasound. Treatment: endoscopical injection, medical treatment, amoxicillin or ampicillin, infants younger than 6 weeks, trimethoprim, sulfamethoxazole, cotrimoxazole, 6 weeks to 2 months. After 2 months, the following antibiotics are suitable: nitrofurantoin, 5 to 7 milligrams to 4 kilograms for 24 hours. Nalidixic acid, Bactrim, trimethoprim, cephalosporins.
Great advantage of the injection therapies is the lack of specialist equipment. Here you can see we have a simple cystoscope with a working channel. Any model would do. I use a semi-rigid needle, but a rigid or flexible needle is fine. And the deflux itself. Using a standard cystoscopy either under general anaesthetic or local with sedation. Here we can see a nice open bladder neck, which is an ideal patient for this form of treatment. I'm aiming to get the injection about 1 centimetre back from the bladder neck itself, and I think this is an important part of the treatment. Here you can see the bladder neck. We're just coming slightly further back before we put the injection. Too close and I think you lose some of the product. We pierce the urethra itself, and then under direct vision I will inject between 0.5 and 1 ml of deflux at the first site, depending on how well the cushions are forming and how well the urethra is bulking up. Here we can see a nice result with the urethra swelling up nicely towards the midline. Once the first injection has been put in, you've got to be sure that you withdraw the needle every time into the cystoscope fully while the nurse is changing the deflux syringes over, and then look again, coming back 1 centimetre, and you can see here how where you push forward the urethra creeps, so that's why it's important to get that 1 centimetre further back before you put the injection in. And again, the bulking of the cushion can be seen filling out nicely. I tend to put the first 2 mils in and then assess to see whether any further injection is needed. Often there's a slight defect at 6 o'clock in this patient. As you can see, there's a slight defect at the 12 o'clock position. These filling out between the 2 cushions, and that's why we're using the 12 o'clock injection. I think you have to adapt it for each patient depending on how the first 1 or 2 cushions form. Here again, we just see filling up that 12 o'clock defect and closing off the bladder neck, as we can see from this picture now, and the sort of result I'd be looking for at the end of my cystoscopy.
Conclusion: antibiotics do not prevent APN nor renal scarring in patients with mild or not VER. Thank you, ladies and gentlemen.